Good afternoon, everyone. My name is Kate Vanny, and on behalf of URI Foundation and Alumni Engagement, I'd like to welcome you to our program today. We're happy to present our first faculty office hour discussion for the spring semester. This semester, we're partnering with the URI magazine to provide additional content related to the feature story in the upcoming spring issue, which is about navigating healthcare. Today, we welcome two professors from the College of Nursing to discuss their work supporting young patients with complex healthcare needs. For these patients and their families, getting the care and support they need can be complicated and overwhelming. I'm pleased to introduce Dr. Ann Marie Moraitis and Dr. David Geyer, who will share some of their research and discuss how their work could help patients have better care and improved health outcomes. If you have questions for the faculty today, please post them in the Q&A section on our screens. We'll do our best to get to as many questions as we can after the presentation. And just a note, today's program will be recorded. In a few days, you'll receive an email with a link to the recording, along with recommended resources for further reading. You'll also be receiving a very brief survey from us. We welcome your feedback. Now, I'd like to invite Dr. Moraitis and Dr. Geyer on screen to introduce themselves.
Hi, everybody. My name is Ann Marie Moraitis, and thank you for inviting us here today. I'm a new assistant professor in the College of Nursing with a clinical background in pediatric ICU, early intervention, as well as other settings. And as a nurse scientist, my research aims are in health promotion, specifically physical activity in youth with cancer. I'd like to let my colleague David introduce himself.
Thanks, Ann Marie. I am Dr. David Geyer, also an assistant professor here at the College of Nursing. I will tell you all a little bit more about myself when it comes time for my presentation, but I will tell you now that I'm a pediatric home care nurse and a pediatric nurse practitioner as well, and I look forward to sharing my research with you shortly.
As we speak, David and I will both share research, and please, we'd love to answer questions after our presentation. Feel free to enter those into the Q&A box, and we'll do our best to answer as many as we can. So again, my talk today is on adolescent and young adult cancer survivors, physical activity and digital support. I think it's important to know the lens that I'm approaching this from. So my clinical experiences, as I mentioned, are heavily concentrated in the care of youth. I also obtained a master's in clinical exercise physiology here at URI. That's considered kinesiology. But clinical exercise physiology helps move people towards wellness in chronic disease states with training in cardiac rehab, metabolic rehab, pulmonary rehab, and now in cancer settings. And it's here that I first started my research in what's kind of considered cancer energetics, so cancer and health promotion. I received my PhD at UMass Amherst, working in cancer survivorship symptom management through at-home toolkits, and then did an NIH funded postdoc at the University of Utah with a focus on cancer digital healthcare delivery for symptom management, and spent some time at Dana-Farber last year prior to commencing here at URI in their survivorship clinic. So just a quick overview. I want to come quickly to adolescents and young adults with cancer, but the research is limited, so I thought I'd start with just an overview of physical activity in cancer. Most of the research has been in adults. We'll move then into adolescents and young adults. I'll talk a little bit about digital support in cancer care, and then my hope as I move along through URI. So again, some key terms, so we have some shared understanding. Physical activity is really includes all forms of movement done in occupational, recreational time, household, and transportation. So it's a little bit more inclusive than exercise alone, which is really appropriate when you think of cancer survivor and what they may have the bandwidth for. So physical activity in cancer positively impacts our physical health, our mental health, decreases symptom burden and chronic disease risk, as well as has biological impacts. And I don't want to get deeply into those because this is high level, but things like inflammation, cellular regulation, how our cells grow, repair, how they turn on and off and communicate with one another, including how we grow blood vessels to provide nourishment and oxygen, insulin pathways, our immune system, and bone health. So a cancer survivor is an interesting definition. So it is inclusive of those people living with or beyond cancer diagnosis. And the recommended definition is that survivorship starts at the time of diagnosis and continues through one's lifetime. This is a full slide, and what I really want you to know is that cancer and its treatments often affect multiple systems in our body. Symptoms are often underreported. They can occur during treatment, they can persist for years, and they can also pop up as late or long-term effects long after treatment. Obviously, the type of cancer and the type of treatment will influence the type of symptoms experienced. So I'm just going to highlight some high-level symptoms here. Fatigue is the most common symptom, and it is estimated, it's a wide estimate, between 30 to 80% of patients experience fatigue. It is the most distressing symptom. And I think what's really important is that guidelines show right now that physical activity is the only effective treatment for fatigue in cancer survivors. Pain is also a very distressing symptom, and 10% of cancer survivors here in the US experience pain not only during treatment, but oftentimes persisting for years after their initial diagnosis. And I'll tell you the effects of physical activity on pain. Some additional symptoms that are frequently seen are anxiety, depression, cognition changes, sleep disruption, altered function, physical function and strength, and worse quality of life. So what is survivorship care? Survivorship care helps to mitigate all of these things. So it's really symptom management. It's risk surveillance for late and long-term effects, secondary cancers, or advances of a primary cancer. It really focuses on quality of life enhancements as well as health promotion. So overall, again, most of this research has been in adults, but there's positive effects of physical activity, including improved symptom burden, improved quality of life and well-being, decreased risk of chronic disease, and improved mortality. So for this reason, there are a multitude of governing bodies that have established physical activity guidelines as a standard in cancer care, both during and after cancer, including the American Cancer Society, the American College of Sports Medicine, the World Health Organization, the American Society of Clinical Oncology, and the National Comprehensive Care Network, which is actually a band of cancer centers across the US that have formed an alliance to improve cancer care. So not only do they develop and disseminate evidence for healthcare providers across the world, but they also provide guidance that's directly available to patients, written in plain language so that they can easily access it. So why do they have guidelines for physical activity? And it's because of its positive effects that have been seen. So again, there's improvements in fatigue, bone health, anxiety, depression, physical function, sleep, pain, and quality of life. And the research is continuing rapidly. So you may ask, like, how much? So the American Cancer Society, the American College of Sports Medicine in 2019 were the first people to actually make exercise guidelines for people living with and beyond cancer. You'll notice they're a little bit different than the guidelines that we have for the general population. But they write it as an exercise prescription, again, for both during and after treatment. So it's recommended that in order to have an impact on these symptoms that are mentioned here on the left, that you have 30 minutes 3 times a week of an aerobic exercise, moderate. So that may mean that you can talk, but perhaps can't sing. There is new research looking at just minimizing sedentary behavior, so not even getting to moderate intensity, and it's exciting to watch that unfold. But the research has also looked at kind of splitting up time. So again, when you're looking at someone with fatigue, splitting up time is important. So it's minimal. And you may say, well, how much? So there's several clinical research studies that have looked at kind of a single bout of physical activity and how it actually impacts the environment that cancer cells live on. And they're seeing positive effects on immune. It alters our hormones like insulin or growth factors. And all of this really creates a more favorable environment for our immune system to function. So, you know, as this research is rapidly unfolding and there's a call for more research, I think what's hard right now is that physical activity patterns are not captured standardly in the electronic health records. So there's been a push to capture it so we can kind of have a longitudinal view of all of its effects. So I want to focus a little bit on improved mortality. There has been large population studies that have looked at mortality and found consistent evidence that physical activity improves longevity in all cancer survivors. And it's important to note that this is even in advanced stage cancer, they've seen improved mortality. So let's talk finally about adolescents and young adults now that I've shared kind of the research that was mostly in adults. So adolescent and young adult cancer survivors is a huge age range. So it's ages 15 to 39 years of old. Here in the US, there are over 84,000 diagnosed each year, and globally there are 1.2 million. Why are we looking at AYAs? What is it about them? They are underserved. They often straddle adults and pediatric care. They are understudied. They have longevity of cancer survivorship, so up to 50 or 60 years. And on this next slide, I'm going to show you that although cancer rates across the world are decreasing, they are getting much larger in adolescents and young adults. As you can see, the blue line is the increase that we see in this age 15 to 39-year-olds. So it's really important that as we see these rapid increases, that we really pay attention to this age group. So greater than 85% will actually survive their cancer, which is great. But there's a wonderful term that was coined by a researcher called Kopp in 2016 that talks about the consequences of the cure, which are great for this age group. So while there's great research going on trying to understand about this rise, it's also important that we take care of the people that already have cancer and how do we provide support to them. So adolescent and young adult cancer survivors experience the greatest symptom longevity and sequelae compared to pediatric and adult cancer survivors. They also face disproportionately elevated risk of developing chronic disease, for instance, cardiometabolic dysfunction, compared to peers without cancer. Therefore, regular physical activity is recommended as the standard of cancer care, as it's been shown to lessen treatment side effects, symptom burden, and subsequent chronic disease risk while improving quality of life. So just as far as the chronic disease risk, adolescent and young adult cancer survivors have a 2-time incidence of cardiovascular disease compared to their non-cancer peers. They also are increased for hypertension, elevated cholesterol, and compared to those, so cardiovascular disease, as I said, is 14% compared to 7% in the regular population. Hypertension is 35% compared to 29%. They have high levels of disability, almost double, so 36% have disability in their life as opposed to 18% in the general population. They have higher risk of asthma and diabetes. And I think it's interesting to note that this cardiovascular disease is even more elevated than childhood cancer survivors. So this all got me interested to understand how I could make a difference. And so during my PhD, I set out to really understand what clinical experts thought about the use of physical activity in adolescent young adult, as the research was so limited. And during this time, the adult guidelines came out. So my dissertation was a modified Delphi study. And so really what I was seeking was to gain expert consensus on physical activity use in adolescent and young adult cancer survivors. And so I had a team of international experts. They had expertise in adolescent young adult oncology, survivorship care, rehabilitation, and exercise oncology. Again, those who study exercise in cancer populations. I explored their guidance on having physical activity guidelines and implementation considerations. And this is what we found. So we found that there's an amplified need to promote physical activity in adolescent and young adult cancer survivors at all stages of cancer care. So whether it's at diagnosis, during treatment, early survivorship, or later on in survivorship. My experts highlighted the untapped potential of digital intervention and innovative implementation strategies to improve care for the adolescent and young adult cancer survivor. And they clearly stated that adolescent and young adults needed to be involved in creating interventions to support them, very much coinciding with nothing about us without us. So what are some of the priorities in adolescent and young adult cancer care? So current research indicates that they are often lost in cancer care transitions, leading to a multitude of preventable unmet needs. They often straddle, as I mentioned earlier, pediatric and adult cancer survivorship symptoms that are not tailored to their life stage or their needs. Survivorship care plans and survivorship care clinics are something that they don't often engage with. And there's a lack of communication between their oncology team and their primary care team. And all of this leads to a lack of regular follow-up, including in health promoting activities. So I sought a postdoc out specifically in cancer with a focus on symptom science and digital innovation to really understand how digital health would impact cancer care. Because we know digital health has lots of benefits, but especially in adolescent and young adulthood, where they are digital natives. So let's quickly talk about my experiences in digital support in cancer care, which were mostly adult focused. So why digital support? We know that it helps with unmet needs. It helps with prevention measures, symptom management, and long-term health monitoring. It provides equitable access to care. It allows for more frequent interaction with cancer survivors so that their symptom burden doesn't get high. It decreases unnecessary healthcare utilization from unplanned emergency room or hospital visits. And it really allows us to be in real time engaged with the cancer survivor in their natural environment. So I'll just tell you a little bit. So during my postdoc fellowship at the University of Utah, which was in cancer, caregiving, and end of life, I was mentored by Dr. Kathy Mooney. And during this time, I gained expertise in how to optimize health promotion interventions and care delivery systems using digital technology. Specifically, I was involved in Kathy's Symptom Care at Home platform. This is a remote, again, think of Utah, right? So this is a remote symptom monitoring platform that tracks symptoms for those undergoing cancer treatment. So this was during their actual treatment, and it does this at home. So it provided automated monitoring of symptoms, education, and coaching that was responsive in real time to their experience. This work, again, was done in adult populations with a diversity of cancer diagnosis, and all of the studies found great effect in decreasing symptom burden and unplanned healthcare utilization. So I did a secondary analysis. Some of this work had a physical activity component, and patients were randomized to usual care or the Symptom Care at Home platform. And the platform, the physical activity support and coaching was actually triggered once a symptom was present. So a symptom of fatigue, nausea, vomiting, or anxiety were reported, and they were coached on the benefits of this, and then nudged if they so wanted to set a physical activity goal. They were tracked, the system remembered and kind of checked back with them. And again, this idea that they were nudged is an interesting concept, because often when people are undergoing cancer treatment, kind of giving them one more thing to do is not what they're looking for. So it used the principles of behavioral economics. So we examined uptake, physical activity, goal setting, and symptom severity. And what did we find? We found that the Symptom Care at Home platform specific to the physical activity module was feasible, acceptable. In our sample of 102 participants, there was statistically significant reduction in overall symptom severity. And I think what was most encouraging to me was, we often think of cancer as a time that's just so overwhelming and, new things are not going to happen. But in our population, over 71% were people who considered themselves non-exercisers at the start of this, and they were willing to accept this and take a goal, set a goal because they thought it would make them feel better. So here at URI, that I've been here since August, I really plan to bridge these past experiences and move forward with my research in physical activity and digital intervention, specifically tailored to adolescent and young adult cancer survivors. So I think all of us have a why in our research, and my why involves a dear friend who was diagnosed as a young adult, and when she went on, charged me with making a difference in bringing physical activity as a standard of care for adolescents and young adults. The stats for adolescent and young adults are also overwhelming. I want you to look here that over 75% are actually asking for physical activity support during and after treatment, but engagement is less than 5%. So despite these guidelines to remain physically active during and cancer treatment, most cancer survivors of any age do not meet these guidelines. It's estimated less than 15% are actually even advised to be physically active during cancer survivorship. So unfortunately, adolescent and young adults are showing similar patterns. They have low levels of physical activity compared to their non-cancer peers. They exhibit high levels of sedentary time, and their levels of physical activity post-treatment are lower than what they were pre-treatment. So further interventions to sustain physical activity are lacking. And given the fact that they have these high symptom burdens, this increased chronic disease risk, and they spend upwards of 50 years as cancer survivors, it has now been recognized as a high priority in cancer survivorship care. As we see, they're asking for support. So I feel like as nurses, as providers, we need to provide them with that. So I have lots of research questions that I'm starting to answer with my work, such as what are the patterns of physical activity change? So what happens during that time, like from pre-diagnosis to diagnosis to immediate post-op? And the reason we need to know what happens is we need to understand with these contextual nuances, how can we intervene earlier so that that pattern doesn't get started? We want to know what information they received and from whom. Who do they want to receive information from? Was it helpful for them, or did it feel like it was shaming to them? Or were we really supporting? If no information was received, what would they want to know? We also want to further the science in symptoms, and particularly how physical activity interacts with mitigating those symptoms. So it's hard, again, to capture physical activity right now because it's not a standard, even though we're asking for remaining physically active to be. So we do have to have an ear towards implementation strategies. What online resources are they using? What would they want to use? So in regards to digital physical activity support, we want to have something that's responsive to the symptoms that they're having. What are the basic components that are necessary, and what additional components may need to be added for certain populations? So as a researcher named Fitch said, adolescents want care that fits me, in a study that she did. It's important that we consider this normative life stage, and it's a time of independence, autonomy. There's geographical changes with education, jobs, and partnerships. So we really need to kind of create something that fits where they are in life. So in order to build care that fits me, I have created an adolescent young adult advisory board that will guide not only all of my research endeavors, they have lived experience of being an adolescent young adult cancer survivor, and collectively they will hold me accountable to create tailored supportive digital physical activity interventions that match their needs. I'm also currently preparing a federal grant to co-design a physical activity with youth. This work will involve human-centered design. It's a problem-solving technique that puts real people at the center of the developmental process and enables us to co-create products and services that are tailored to their needs. As an approach to creative problem solving, I will also be using the Discover, Design, Build, and Test framework, which will foster physical activity intervention design that considers not only the design, but also implementation. Thank you guys for your patience. I have some resources that I think we're going to share, and I'm happy to answer any questions, and thank you very much.
Thanks, Anne Marie. It's always nice to learn and hear about your work. And I'm really excited to now switch over and share just a bit about mine before we switch over to questions. So I am going to share my screen and start my PowerPoint for you. Okay, so as I mentioned when I was introduced, my name is Dr. David Geyer. I am an assistant professor here at the College of Nursing at URI, and my presentation title really summarizes what my research is all about, which is addressing the systemic challenges of caring for children with medical complexity at home. And usually when I share my research interests with folks, I get a little bit of a glazed look sometimes because those are a lot of terms that people aren't familiar with. And so what I'm going to do in this presentation is break down that title so that everybody understands what I mean and what challenges I'm addressing and who should be caring about this and why it's important. At the foundation and at the core of my research is actually my nursing career. When people find out that I'm a nurse, I always get the question, "Oh, which hospital do you work at?" And interestingly enough, I've never worked in a hospital throughout my entire nursing career. I have worked in the community and primary care setting my entire nursing life, if you will, in two separate and very important roles. I continue to practice in both of these roles. The top being as a pediatric home care nurse. It's been about 6 years since I started that role. And as the name sort of implies, I am working in the homes of pediatric patients. Meanwhile, as a pediatric nurse practitioner, I'm working in a traditional primary care office, or as most folks say, a doctor's office. And I run a lot of well child visits or physicals, sick visits, particularly for kids who wake up with a sore throat and the parents have to decide if they can go to school or not. So they come see me to figure out what the heck is going on with that sore throat. I love both of these roles. That's why I haven't given either of them up. But it's actually my time as a home care nurse that really inspired me to even go and get my PhD in nursing and what continues to propel me forward in my research. And there's a lot of nuances with home care nursing. Not everybody knows what exactly that means. And so what I want to tell you a little bit about is what do I see and who am I working with? There are two main groups of folks that I'm interacting with in this role. The first being my patients, and my patients are a type of pediatric patient or population known as children with medical complexity. And you see four statements underneath that phrase. Those are the defining characteristics of this population. So a child to be considered medically complex has to have one or more complex chronic condition, experience some form of functional limitations because of that condition, require some form of life-sustaining medical equipment to compensate for the limitations that their body is experiencing, and subsequently requires a very intense level of care coordination. A really nice tangible example would be a child who has severe cerebral palsy, or CP, which is a neuromuscular condition that most folks are familiar with. So that condition already meets the requirement to have a complex chronic condition and be considered a child with medical complexity. Having CP, especially a severe form, can in turn cause some form of functional limitations with their neuromuscular system, the digestive system, perhaps the pulmonary or respiratory system. And because of those limitations, right, that part of the body cannot work the way it's supposed to, these children end up requiring medical equipment. And that could be a wheelchair because they might not be able to walk and get to where they need to go, or a feeding tube because they're not able to eat by mouth, or perhaps a trach and or a ventilator to provide respiratory support because they cannot breathe on their own. Having a child with that diagnosis and those needs, as you can imagine, then requires a lot of coordination, making sure equipment is available, making sure that providers are available to support these needs. And so somebody has to be there to coordinate all of this care. And that somebody is the second major population that I'm working with in this role as a home care nurse, which we call in research the parental caregivers, right? So these are the adults, typically the parents, though this could be any legal adult, perhaps a grandparent, an extended relative, an older sibling, who is legally the guardian of a child with medical complexity and is their primary responsibility to make sure this child gets the care they need. As a home care nurse, I am supporting the parental caregiver in making sure that this child receives the care that they require. And there's a little bit of a misnomer in calling this a home care position because these children require care not just at home, but at school. Many of them are in classrooms learning alongside their classmates and at different appointments, whether they be a scheduled or unscheduled doctor's appointment. And I like to also say pretty much anywhere where you've seen a child in your life, there can be a child with medical complexity, and therefore there is likely a home care nurse trailing right behind them. And what I quickly saw when I began my job as a home care nurse, and what I continue to see now 6 years later, is that these parental caregivers, not only is it their responsibility, it's really just them who is responsible for every single aspect of these children's care. And when I talk about care, what type of care do they require? There are some broad categories that we typically talk about with care. The first being medical equipment. By definition, these children are dependent on life-sustaining medical technology. It could be a feeding pump, which is the top photo there, a wheelchair. Medicines themselves are considered medical equipment, and it is the responsibility of the parent to ensure all of this is available and accessible to their children at all times. Because as soon as you start to take away any of this equipment, the child's life could be at risk as they are dependent on this medical technology to sustain life at home. Also, per criteria, coordinating care. It is an average 10 to 20 subspecialists per child with medical complexity, meaning one child can have up to 20 people, separate teams responsible for their health care and for their quality of life. And it is up to the parents to make sure that amongst all those 20 people, they not only communicate with themselves as providers, but any recommendations they may put forward for the child's health needs to be seen and followed through. And so parents are the ones scheduling follow-ups, new appointments, additional testing that needs to be done for the specialist. It's on the parents' shoulders to make sure all of this gets done. And while accessing these two types of care is really, really important, unfortunately, it's not always covered by insurance. So although a specialist may say this child needs to be on a certain medication, insurance may not cover the cost of providing that medication to the child, which leaves parents in a really uncomfortable space of having to decide either foregoing that treatment because it is too expensive and unaffordable, or paying out of pocket. And a study that I did actually found that parental caregivers of children with medical complexity are almost 35 times more likely to spend at least $5,000 a year on out-of-pocket costs for their children when compared to parents who do not have a child with medical complexity. $5,000 a year at minimum is a lot of money. I certainly don't have that money lying around to spend every year. And this is on top of all of the other responsibilities that families face, like home improvement, or the car broke down and we need a new tire, a new engine. So on top of all of those costs, parents have to now manage these additional costs when insurance does not foot the bill for something that their child requires. And even though we do have a very clear definition of what and who children with medical complexity are, I always remind folks that at the end of the day, they are children. And so parents' main goal for their children always is quality of life and ensuring that these children experience life in the most beautiful, peaceful, and enjoyable way possible, whether that be through interactions with their siblings and extended family members, their classmates at school, play dates, vacations, you name it. As I said before, if you've seen a child somewhere, you'll see a child with medical complexity there. And it's amazing how quickly you realize that the world is not always set up to include everybody in some of the most exciting places to bring a child to. Debatable whether school is the most exciting for most kids, but there are often a lot of barriers, even within our education system, for these children with medical complexities. So those are some of the major responsibilities these parents are carrying with them. And unfortunately, what we have seen is that these parental caregivers are burning out. They are telling us as providers and as researchers that having all of this responsibility feels like carrying the world on their shoulders. And it's not just because the responsibilities themselves bring significant stress, right? Bringing a newborn baby home is stressful enough. Bringing home a newborn baby that has a feeding tube and a trach and a ventilator, and you as the parent now have to learn how to manage all of this at home with no medical knowledge prior to the birth of your child is stressful. Parents always tell me, I have to learn how to keep my child alive, and they're not being dramatic when they say that. So that alone is stressful. But then what parents are experiencing are significant barriers to getting the care that their children require. We talked about insurance not covering equipment as one example. Not having enough home care nurses available, such as myself, to support these families is another barrier. And every time a barrier arises, these parents are making physical, emotional, and financial sacrifices. Because if they do not, the care their child requires is not received, and then their child's life becomes endangered. And unfortunately, these barriers are not simple challenges that can be avoided by maybe moving to a new town or moving to a new state. Many of these challenges are grounded in the socio-political climate in which we live. And another way to say that is health policy. There are so many health policies, both at the federal level, the state level, and even within hospital systems that can really make it challenging to have these children live at home and get the care that they need. And above that, even though we know that these challenges exist, these parents are telling us they don't have a lot of resources to guide them through these challenges. They basically get set out into the world with this child and are told to figure it out. And when I completed a study interviewing parents who have children with medical complexity in Massachusetts, where I started my practice, one mom kind of succinctly said what the problem is. And I have this quote here from her. And she said, there's no manual for kids in general, but there's not even a compass for these kids, which just speaks to how lost and uncertain these parents feel when they come home with their child and how to get the care their child needs. Now, this is a problem for a number of reasons. One, these are human beings that are struggling. And for me, that was enough of a reason to say I need to do something about this. But this is also a problem that's not going away. And here's why. One, children with medical complexity as a population is increasing in this country. In about a decade, the number of children with medical complexity actually quadrupled to an estimated 1.2 million children, which is about 2% of all children in the US. I will say that that data were collected about 10 years ago, so it's a little outdated, and I would estimate the number to be higher, maybe closer to 1.5 million, if not more. We don't have a great way to track, similar to what Ann Marie was talking about with physical activity. Not a great way to track how many kids really are in this country, but knowing that the number is growing, we also know that the number of parental caregivers is growing. On top of that, the children that are coming home with medical complexities are coming home with more complex diagnoses and needs. There are so many more parents today compared to 40 years ago when home care first started for pediatric patients that are providing ICU level care in their homes. ICU level care means ventilators, trachs, central lines, which are permanent IVs, feeding tubes, epilepsy management, the type of care that even amongst nurses, not everybody feels comfortable providing. And we are having parents doing this level of care at home. And with that increased complexity means that parents are shouldering increased responsibilities in navigating all of the needs that their children require. And on top of that, the life expectancies of these children is changing rapidly. These children are living longer, and now children who used to pass away from diagnoses are living into adulthood and young adulthood. But there's not really a clear landscape of what to do when these children reach that age, because many of the regulations that exist in home care have age caps. We kind of support these kids until they're about 18 to 22 years old, and then a lot of these supports start to dwindle away because nobody thought about what happens after the child turns 22. Their needs are still there despite their chronological age changing. And because these children are living longer, parents are caregiving longer. So without addressing the burnout that parents are already experiencing, it's only going to continue to get worse. And failing to address this caregiver burnout really endangers the well-being of both parents and their children. Which is why my research, going back to my title, is all about addressing the systemic challenges that these parents face. And addressing these challenges, I kind of have two arms to my research. I have the arm that talks about and looks at how do we develop supports for these families and understanding how to navigate this landscape. And then the other arm of advocating for change, because just because things are broken right now doesn't mean it has to stay like that forever. And so what can I do and what can we do as a healthcare team to promote change so that these barriers start to disappear slowly but surely? One example of developing a support, listening to that mom who said that there's no compass for these families. I'm currently working with families to develop this compass, right? I like to describe it as a guide that's developed by parents for parents to really understand how to navigate these systemic challenges. And we're looking at the common challenges that parents face in determining what should be in this guide. It is in the preliminary stages. I'm really looking forward to seeing it kind of expand and turn probably into more of a digital component and resource, thinking a lot about some of the components that Ann Marie shared about what platform would work best, what resources do you need, what are you already getting? And so more to come on that. And then from an advocacy standpoint, right, I told you that health policy is really the biggest barrier and the biggest contributor to many of the challenges these families are facing. And one of the hardest parts for families and providers alike is that most of the community programs that exist for this population are supported and funded by Medicaid waivers. And Medicaid can be tricky because there's the federal government that's putting money into these programs, and then every state government puts a certain amount of money into these programs. And states do have a little bit of flexibility in determining how much money and what programs they would like to offer, not just for this population, but for any Medicaid recipient. Home care nursing, which is the job that I shared I do, is one of these programs. And unfortunately, because Medicaid waivers are funded differently from one state to the next, the opportunities and the services that are available to children and families vary from one state to the next. And even more unfortunate is the information that describes how these waivers are different is really hard to find. So my undergraduate research fellow here in the College of Nursing and I have been working on compiling all this information, scouring the webs, sites that we didn't even know existed to identify where these regulations can be found and how do parents get access to it. And our hope is that we can identify and put forth the states that are actually making this information accessible, the states that are not, and compare why that is, and put forth some guidelines and recommendations for what all states should do to ensure that families have access to this information. I would be remiss not to also mention that community programs, because they are Medicaid funded, with the current Trump administration putting forth the notion of cutting funds by $880 billion over the next 10 years, these types of programs are at high risk for being completely eliminated should the proposal be enacted, which means that these families would lose access to various community programs and in worst case scenario could force families to have to put their children regardless of age back into the hospital or long-term care setting because there will not be programs available to support their life at home. In the meantime, as we kind of see how things unfold, there are still things that I can do as researcher, which I shared, and also all of you can do regardless of what your profession is and whether or not you're in healthcare or research or what have you. All parental caregivers tell me that they feel so invisible. They feel like the society at large doesn't realize how hard it is to have a child with medical complexity and live at home and the responsibilities they feel. And when somebody feels invisible, the most valuable thing you can do is to see them, validate them, and tell them that you're there and you hear their experience. You might not know what it feels like, but you're at least willing to learn. There are lots of families who post about their stories and their experiences on social media. And through that, you can actually also learn about some of the local grassroots campaigns that your town or your state may be doing to address systemic challenges. A lot of the time, these campaigns are initiated by parental caregivers themselves, and they are the best to identify what needs to be changed to support them. But that does not mean that they have to be the only ones fighting for this access. We can be there alongside them, amplifying their message and amplifying their voices. If you're able to financially donate, there are tons of nonprofit programs and services at the state and national level that provide different supports to children with medical complexity and their families, such as Make-A-Wish and home improvements, right? If maybe your child's coming home with a wheelchair and you don't have a ramp, there are groups that will go out and install those ramps for free because of the funding they receive through donations. And educate yourself and children in your life about children with medical complexity. This will be shared with you after the webinar, but there is this wonderful book called Let's Go Play that I've ordered several times and shared that talks about different children with different adaptive equipment, like a wheelchair, feeding tube, and trachs, and shows them playing with friends in very fun, imaginative ways, and is a great way to start a conversation with children as young as 3 about what to do and how to interact with a child who may look a little different than you, but just wants to play just like every other child. And then on Disney Plus last year, this amazing movie based off of the book Out of My Mind shares the story of a 6th grade girl with cerebral palsy or CP who is nonverbal and the challenges that she and her family face trying to get equitable education services to her in a school that only sees her for her disability. It was incredibly moving. I cried several times and I recommend it to anybody. Again, family friendly and really just shows the nuances of caring for kids with medical complexity at home in a really beautiful way. So my major takeaways for all of you is to remember that children with medical complexity are unique and they are a growing pediatric population. They are here to stay. Unfortunately, the parents who are caring for these children will continue to navigate tremendous amounts of systemic challenges while trying to care for their children. And they're burning out. But regardless of who you are, what role you play in your job, where you live, all of us can play a part in supporting these families, even if it's just by attending a webinar like this to learn a little bit more of who's out there and what we can do to help them. So that's the end of my presentation. I'm going to stop sharing. And at this time, I am going to have Ann Marie join me on camera, and we are going to answer a few questions from the audience. As a reminder, if you do have a question, please pop it into the Q&A section, and then we will take turns addressing them as needed.
I have a question for you, David, but I'm going to answer. So Dr. Degata, in answer to your question about why is it that long-term health risks are greater for adolescents compared to pediatrics or adolescent young adults, that is a question that researchers have been rapidly trying to answer. I will tell you that as this rise in adolescent young adult cancers is happening, what they're noticing is the disease presentation is so unique. So for instance, in colorectal cancer, the presentation for the AYA population is totally different than what it would be for, say, a 55-year-old. So it's much more aggressive. It's located in a different part of the colon. And so again, they're not exactly sure why that is, but the presentations are different. And then David, there's a question for both of us. Are there other states that have established programs that may serve as a model? I will tell you that there's some incredible survivorship research programs, some that are trying to incorporate. There's a tremendous amount of trying to address their psychosocial needs, trying to address sexual health needs, infertility, financial toxicity, all which are so important. Surprisingly, very few are actually incorporating anything with physical activity. And I think what they're finding is that a lot of these adolescent young adults are really not engaged in survivorship care. So there's not even numbers. I remember when I was at Dana, I was like, well, how many people do you see and how many engage in survivorship? And they don't even track it, but they think it's like 2/3 don't even actually get that type of care. Hence why digital makes sense. David, please, you've got some questions too.
Yeah, unfortunately, this is a really hard problem to tackle for states. And again, I think it really comes down to it just being funded by Medicaid and having that be the core of most of the programs. There are no states that have done it perfectly. There are 4 different types of Medicaid waivers that a state can adopt in order to provide such home care programs. One of those options is a state plan program, which Rhode Island did adopt. It is something that you have to prove to Medicaid every few years that your program is cost saving for Medicaid and therefore can continue functioning the way the state proposes. And there are some strengths to that because you can usually incorporate positive attributes of other waivers into your own state plan. They're incredibly hard to maintain, and you need a lot of buy-in from stakeholders to even consider developing a plan like that. There are certain states from a, private duty nursing or home care nursing perspective, there are some states that have really knocked it out of the park in just making all that information accessible. How do you get nursing? How do they calculate how many hours a week your child is eligible for? How do they reimburse the nurse? What does that care look like? And then other states, unfortunately, just kind of make it a little bit of a gray area. I do see that somebody had shared with me, thank you so much, about I've heard it pronounced differently, the RIPN or RIPN, Rhode Island Parent Information Network. Thank you so much. That is a group that is on my radar, especially moving away a little bit from Massachusetts and looking at some other states and the groups that are available to them. Anne Marie, I'm going to echo this question to you. Being your own healthcare advocate can be intimidating. How do you recommend that families or patients approach advocating for their healthcare?
So I shared with Leslie, who's really being so great to guide David and I through this whole thing, some resources that I'm hoping she can share. I'm sorry that I didn't put them in the chat, but some are specific just to free places that can support physical activity during cancer survivorship. I will tell you, I got certified in kind of cancer exercise kind of rehabilitation. It is all geared towards adults. So all 3 of those are adults. But I also shared some other organizations that are specific to AYA. Again, They don't necessarily talk about physical activity, but they offer support, and they are actually working with me to try and bring something different. So I hope I answered that question, David. I'm ping-ponging it back to you now.
And for families who have children with medical complexity, there will be also some resources that I put out that will be shared via email for parents who can access. There's some national groups that really help. Family Voices is one. The Lucille Packard Foundation is another. Several others that are specific to the type of diagnosis a child may have, like CP is a rare yet common condition, and so there are tons of CP networks even at the state level to support families who might have a child with CP. But advocating is tough, and learning how to navigate the healthcare system sometimes feels even more daunting than just telling your provider, hey, I think I need to go up on a dosage of my medication. And so I'm hoping that through that compass development, and very similar to Ann Marie's work with the digital health, um, expanding the access to this information and making it more palatable and easier to reach families will help them learn how to advocate better and learn what they should even be advocating for. If we're not telling parents, hey, in 10 years, you're going to lose access to this waiver, how do they know to be thinking about it until they've actually lost it? So that's a wonderful question. And I see one for you, Anne Marie. Why
Yeah.
is research so limited for cancer patients in that young adult age group?
That's a really good question. During my PhD work that I shared with you, where I had international experts, one of the experts was the founder of adolescent young adult cancer, like that whole population. And so I asked him, what, how did this come about? And he was actually an oncology provider, young pediatric oncology provider. And he started to notice that patients that were diagnosed in that age were showing this sarcopenic, so changes in kind of their bone health, and he didn't understand why. And so he started, he was a researcher too, digging deeper and noticing that like this whole group was just lost. And so I want to say it's only been like since the early 90s that they've actually considered it its own group. So it's budding. The research is expanding. The research in exercise oncology is expanding. There's just more work to do. And I'm excited to be here in Rhode Island. There's an incredible amount of research going on at URI and some of our other partnerships here in Rhode Island, a lot of it on kind of the bench science. And so this whole idea of translational research that goes not only to like understanding why and understanding the molecular things that are happening, but understanding how do we care for the people that have cancer. So I see a huge opportunity here.
I did see that somebody mentioned that for parental caregivers in the population of children with medical complexity, oftentimes one parent has to leave the workforce and stay full-time at home with their child and make sure that their needs are met, which is absolutely true. And that opens up a whole discussion of some of the innovative things that some states are doing, like paid caregiver programs and the pros and cons of that, which we don't have time to get into today. But if anybody's interested in learning more, please reach out. I certainly have a few thoughts that I've collected. And, our last question for today's program is, does URI offer classes and or programs to train new healthcare providers to support these populations? And I would say we're both relatively new to URI, so I'm going to speak a little bit more broadly to universities as a whole. Typically, there is no designated class. Um, However, more and more programs are incorporating complex care topics and sometimes even a complex care course. However, in nursing, there's a big focus on inpatient care. And so sometimes we don't have enough time to get into what happens when these kiddos or these patients are not in the hospital, right? They eventually go home, but their chronic conditions go home with them. So how do we support them when they are at home? Um, and I would also add that we are doing a lot of simulation work here in the College of Nursing, and there's been a lot of discussion about using the mannequins and using the different simulation models we have. How do we incorporate some of these more unique, complex patients and cases that perhaps students don't interact with in their day-to-day clinical setting, but could very well see when they go out into practice? Anne Marie, I don't know if you have anything else you want to add.
I have a question I want to ask you, but I think I want to add, no, it is not discussed. And for anyone who is in healthcare, obviously AI and AI capture is huge. And so, but again, there's physical activity, unlike if you had a heart attack and said, okay, you're going to lay in bed for the next 30 days, that would never happen. It would be malpractice. Also a reimbursement issue, despite the science being much greater than when cardiac rehab and pulmonary rehab came into our healthcare systems. Support for cancer, physical activity is not reimbursed unless there is like a tragic, a loss of a limb or something that's, so it's not reimbursed, and there's lots of fights going on to that. But I would say capture it, ask your patients, encourage them. We have to change the mindset of providers. There was a study of nurses, less than 9% of nurses actually talked about moving and being physically active during treatment. So we can change that trajectory. And David, I just want to say, as far as educating, as someone who received patients in the pediatric ICU, I will say the parents were vital to us. They were the caregivers. And so I think the language of listening to parents is huge. Okay. I think that's our last question.
Yeah, thank you.
Thank you all.
Thank you both, and thank you to the audience for joining us. As mentioned, within the next few days, you'll receive an email with a link to today's recording, along with a few of our recommendations for further reading and listening. We hope you'll join us on April 9th for a discussion about navigating healthcare for older adults. Thank you again, and enjoy the rest of your day.